Today we are going to cover Chapter 30 on urogenital pharmacology. The principal functions of both the male and female hormones are to control the reproductive function and secondary sexual characteristics in their respective gender groups. So for the males, we're going to be talking about the androgens in the form of testosterone, and the females, we're going to talk about the estrogens and the progestins. So the androgens are synthesized in the testes in the male, and estrogen and the progestins are produced in the ovaries in the female. Please note that there are a small amount of sex-related hormones that are produced in the adrenal cortex, which we mentioned in previous talks, and these are produced in both sexes, which accounts for the low testosterone abundance in females and small quantities of estrogen in males. So we're going to begin by talking about the male hormones, and then we'll talk about the female hormones later in the talk. So as far as the androgens go, the main one again is going to be testosterone, which is synthesized by the Leydig cells, which are found in the interstitial space between the seminiferous tubules. As you can recall from anatomy, the seminiferous tubules are the convoluted ducts within the testes where spermatogenesis occurs, the formation of sperm. Testosterone production is regulated by the pituitary gonadotropins, LH, luteinizing hormone, and FSH, follicle stimulating hormone. So LH and FSH are responsible for controlling and regulating spermatogenesis, but LH is the primary hormone that stimulates testosterone production, and LH is released from the anterior pituitary gland, and then it binds to receptors on the surface of Leydig cells and directly stimulates testosterone synthesis. FSH is also released from the anterior pituitary, but this hormone affects the Sertoli cells that line the seminiferous tubules and are responsible for the development and maturation of normal sperm. Follicle stimulating hormone stimulates the growth and function of Sertoli cells, and it induces Sertoli cells to produce several products that influence spermatogenesis and androgen function. So as far as the clinical use of androgens, they can be taken orally or they can be injected intramuscularly. And patients are usually taking testosterone and other androgens as hormone replacement therapy when their endogenous production is impaired or inhibited or just completely not functioning at all. Catabolic states occur when the muscle is breaking down, and this occurs in conditions such as chronic infection, severe traumas, severe burns, and as patients are recovering from surgery. So androgens are given in catabolic states to help boost muscle function. The androgens do have beneficial effects on body composition, strength, bone mineralization, glucose metabolism, mood, and libido. The primary concern is that androgens can increase prostate growth, and they can also increase the risk of prostate cancer. Androgens may be used to treat a limited number of hormone-sensitive tumors, such as certain types of breast cancer in women. And as far as hereditary angioedema goes, this is a condition that's characterized by a defect in the control of clotting factors that ultimately leads to increased vascular permeability. So the loss of vascular fluid from specific capillary beds causes localized edema in various tissues, such as your skin, your upper respiratory tract, and your gastrointestinal tract. And androgens are typically given prophylactically to decrease the frequency and the severity of the angioedema attacks. So this chart on the right-hand side of the screen, you can see all these different types of androgens. They're all some type of testosterone derivative in some form or the other. The big thing I want you to know is testosterone is the main androgen that is given for hormone replacement therapy in the catabolic states and to treat particular types of breast cancer. And we also have anti-androgens. These inhibit the synthesis or the effects of endogenous androgen production. And the anti-androgens are useful in treating prostate cancer and other conditions that are aggravated by excessive androgen production. So they're also used to treat benign prostate hyperplasia And the two main anti-androgens I want you to know are finasteride and dutasteride. So both of these drugs inhibit the conversion of testosterone to dihydrotestosterone, also known as DHT. So again, they inhibit the conversion of test to DHT. And they're useful, and this mechanism is useful because DHT, what it does is it accelerates the growth and development of the prostate gland, and these agents may help attenuate this effect. Now moving into androgen abuse. Well, this has been a concern across many major league sports. This has been a concern in the Olympics, and it's actually even a concern in high school athletes at this time. Testosterone and synthetic testosterone are being taken in a dose that's 10 to 100 times greater than the therapeutic dose, and sometimes they're even taken in what's called stacking methods or stacking testosterone. So what that is essentially taking multiple different combinations at one time in different doses to achieve a particular effect. A lot of baseball players have been caught taking Winstrol and some type of testosterone derivative. So what Winstrol does is it essentially depletes your muscles of their water supply, and it essentially makes the muscle look very lean. So in order to get six-pack abs and good muscle definition in the arms, a lot of people will abuse Winstrol. Winstrol is actually a horse steroid that makes the racehorses run faster. And I'm not sure about the legality in horse racing, but I know there has been an issue in horse racing with the amount of Winstrol that's given to the particular horses. So there's also abuse with D-balls, Diana balls, known, the name you guys should know is methandrostenolone. These are very common in Major League Baseball. They're very common in the NFL. It's essentially a cow steroid. It was originally founded to make the beef bulkier and make the cow's muscle generate and proliferate faster. So a lot of athletes are abusing that. The methyl testosterone, this was once sold by GNC in the form of M1T, methyl 1 testosterone. This is no longer available at GNC. The stanozolol, the trade name I was talking about earlier, is Winstrol, very heavily abused still today. And usually you stack one of these orally active androgens with some type of intramuscular injection. So like I said, the patients will take the professional athletes, the professional baseball players were taking Winstrol or D-balls, and they were injecting some type of test derivative, test cypionate, test enanthanate, test propionate, or some other test suspension. So, as I mentioned, not only in Major League Baseball and the NFL is these drugs a problem, but several studies have indicated that high school students are abusing anabolic steroids to accelerate their performance as well. And women too. There's been several cases of women Olympians getting caught for androgen abuse as well. So it's not only in males. And as far as the adverse effects of androgen abuse goes, well, there is a whole plethora of side effects. The first being people who abuse androgens are more likely to abuse other drugs. They can cause hepatic tumors. They can cause many different types of heart complications, dilated and hypertrophic cardiomyopathies, heart failures, different types of arrhythmias, alterations in the blood lipid profiles. They mess with all types of cholesterol. They increase insulin resistance if abused for a long period of time, can cause bone metabolic issues, and definitely the key hallmark of somebody who's taking excessive androgens are the behavioral changes, also known as roid rage. So aggression and frustration and anger seem to be elicited at a lot quicker pace when somebody is taking androgens compared to when that person is not taking androgens. The androgens can also cause hypertension because of direct effects on the myocardium and because of the salt and water retaining properties of these drugs. And going back to the bone metabolic issues, there's been reports of avascular necrosis of the femoral heads, accelerated closure of the epiphyseal plates, which can lead to impaired skeletal growth in children. And essentially, I'm not going to dive into too much about the negative feedback loop, but because of the negative feedback loop of what's happening with the androgen production and androgen inhibition, this is what contributes to the testicular atrophy, the gonads essentially wasting away due to this negative feedback loop and the impaired sperm production. So the question on the bottom, do the pros outweigh the cons? This has been a major debate amongst many athletes, bodybuilders. I'm sure you're all familiar with the governor of California, Arnold Schwarzenegger. Very interesting story of his life. If you ever read his autobiography and see his pictures, definitely took his fair share of androgens. Really interesting to read. So I'll let you all make the decision on whether or not the pros outweigh the cons or vice versa. So enough talk about the males. We're going to jump into the females now. So in women, the ovaries produce two major categories of steroid hormones, the estrogens and the progestins. The primary estrogen produced in human females is estradiol, and the primary progestin is progesterone. So for simplicity's sake, for the remainder of the talk, I'm going to use the terms estrogen and progesterone. So both of these promote sexual differentiation in the developing female fetus and aid in completing sexual maturation during puberty. Now we're going to get into the regulation and effects of hormonal synthesis during the menstrual cycle. So a typical menstrual cycle is a 28-day period, and the primary function is to stimulate the ovaries to produce an ovum for fertilization while simultaneously preparing the endometrium of the uterus for implantation of the ovum. So the first half of the menstrual cycle is influenced by hormonal release from a developing ovarian follicle. The anterior pituitary gland is responsible for releasing FSH, follicle stimulating hormone, which stimulates the maturation of several follicles within the ovary. Usually only one follicle will undergo full maturation and yield an ovum. The developing follicle will also begin to secrete increasing amounts of estrogen, which causes proliferation and thickening of the endometrial lining of the uterus. Also, endometrial vascularization is increased, and the glandular structures will begin to develop in the uterine wall. So that is all about the follicular phase, also known as the proliferative phase. All that occurs there. Now we move into ovulation. Ovulation occurs just prior to the cycle's midpoint, and the anterior pituitary secretes a sudden large burst of luteinizing hormone. And this luteinizing hormone surge drives ovulation, which causes the mature follicle to rupture, releasing the ovum from the ovary. So at this point, the ovum should travel towards the uterus through the fallopian tubes, and the ruptured follicle will remain in the ovary. So after releasing the ovum, the follicle becomes infiltrated with lipids and is referred to as the corpus luteum, also known as the yellow body. So that all occurs in the ovulation phase, and that's the midpoint, and you can see on the chart the LH surge. There is also an FSH surge, but it's not as high. And you can also see below the gonadotropin oscillation, we do have a surge in estradiol as well. So now let's move into the luteal phase. The luteal phase is governed by the corpus luteum, and it responds to the LH-FSH surge, and then it continues. So the corpus luteum responds to the LH-FSH surge, and then it continues to grow for 1 week after ovulation. And during this time, the corpus luteum is secreting both estrogen and progesterone, which aid in the further thickening of the uterine lining, and this causes an increase in the vascularization and the glandular secretion of the endometrium. So during the luteal phase, progesterone is the primary stimulus that causes a mucus that essentially provides a favorable environment for implantation of the fertilized egg. So the luteal phase is also called the secretory phase because of the enhanced function of the uterine glands. So if the egg is not fertilized, or if implantation does not occur, the corpus luteum will begin to regress. And because it regresses, it can no longer produce adequate amounts of estrogen and progesterone to maintain the endometrium of the uterus. So what will happen then is the endometrium will begin to slough off, which creates the menstrual bleeding. And the onset of the bleeding marks the end of one reproductive cycle and the beginning of the next. So this whole mechanism, I know this is a lot of pathophys on this slide. Nothing's going to be tested on this slide for the pharmacology exam, but this is really important for you all to know the pathophys component for the board exam. So there are many different pharmacological uses of estrogen and progesterone. It's the main form of contraception. It's used in hormone replacement therapy, especially in postmenopausal females. It's used to treat osteoporosis, hypogonadism, which is abnormally low ovarian function. So occasionally what's going to happen is the ovaries will fail to develop in some females because of conditions such as hypopituitarism. And estrogen given at that time of puberty may encourage the development of secondary sexual characteristics. It's also used to regulate the menstrual cycle for women suffering from menstrual irregularities, such as amenorrhea, dysmenorrhea, or other types of uterine bleeding caused by some type of hormonal imbalance. It's also used to treat endometriosis, which is characterized by growths of uterine-like tissue that occur at various locations within the pelvic cavity. So some type of progesterone or an estrogen-progesterone combination will help to suppress the bleeding from these tissues and may help shrink the size of these growths. So that's why it's useful in treating endometriosis. And estrogen's also been proven to help treat metastatic breast cancer in men as well as in postmenopausal females. Advanced prostate cancer in men may also respond well to estrogen treatment. And progesterone is helpful in treating uterine cancer and several other types of metastases such as breast, renal, and endometrial carcinoma. So again, you don't need to know all of the names. Just look for something with progesterone or some type of ester in the name of the drugs, and that will help you recognize the estrogens or the progestins on the exam. And just like the androgens have their adverse side effects, so do the estrogens and progesterone drugs. So high and prolonged dose exposure has been associated with myocardial infarction, stroke, as well as thromboembolism. And these problems are really significant in men who are taking these large doses of these drugs to treat their breast or prostate cancer. Excessive progesterone exposure can cause abnormal blood clotting, pulmonary embolisms to occur, and cerebral infarctions. And both estrogen and progesterone may cause transient nausea that's usually resolved by simply when the patient stops taking either one of these drugs or whatever they're taking. And the patient may also complain of swelling of the feet and ankles due to the sodium and water retention effect that these drugs elicit. Progesterone may also alter the normal menstrual cycle, leading to unpredictable changes in the bleeding pattern as well. Now we're going to move into the Serums, the selective estrogen receptor modulators. So how these drugs work is they bind to and they activate estrogen receptors on bone and vascular tissue, including the plasmolipid receptors, and act as estrogen antagonists on the uterine and the breast tissue. So they're selective estrogen receptor modulators. So they're only eliciting an agonistic effect at particular receptors. They're only eliciting their agonistic effect on the bone and the vascular tissue. And they are antagonists on the uterine tissue and the breast tissue. So they have favorable effects while reducing the potential carcinogenic effects of estrogen on breast and uterine tissues. They have very favorable effects on bone mineralization as well as cardiovascular function. And tamoxifen was actually the first serum that was developed for clinical use. And this drug is approved by the FDA for prevention and treatment of breast cancer because it has strong anti-estrogen effects on breast tissues. One of the downfalls about tamoxifen is that it does not completely block the estrogen receptors on the uterine tissues, and it may actually stimulate proliferation and increase the incidence of uterine cancers. But it does lower the risk factors that are associated with the cardiovascular complications. A drug that's prescribed a little more often is raloxifene. This was actually the second serum developed for clinical use and is approved by the FDA. And it's primarily used to prevent and treat osteoporosis in older women. So this drug will stimulate the estrogen receptors on the bone and increase the vertebral bone density, and it will also reduce the risk of vertebral fractures in postmenopausal women. And it is more selective, and as the name implies, a selective estrogen receptor modulator. It completely blocks the estrogen receptors on both the breast and uterine tissue. So this is a factor that tamoxifen lacks. So again, raloxifene completely blocks the estrogen receptors on both the breast and the uterine tissues. The anti-estrogens are used to antagonize all the effects of estrogen. So they bind to the estrogen receptors in the cytosol, but they do not cause changes in cellular function. So these drugs block the effects of estrogen by occupying the estrogen receptor and they prevent estrogen from exerting a response. So sometimes women will take clomiphene, an anti-estrogen drug, to help treat infertility. And another drug on the market is fulvestrant, and this is used to treat estrogen-sensitive breast cancer. And then we have the antiprogestins. These were originally developed in the 1980s as an abortifacient, some type of drug method to terminate pregnancy, and they're actually still used today. So these drugs that are listed, mifepristone is usually combined with misoprostol, and they can induce abortion in the early stages of gestation. So because progesterone is largely responsible for sustaining the placenta and fetus, the blockade of progesterone receptors in the uterus will negate the effects of this hormone with subsequent detachment of the placenta and loss of the placenta hormones such as beta human chorionic gonadotropin hormone, also known as beta HCG. Beta HCG, as you can recall from pathophys, is the pregnancy hormone. So when a woman becomes pregnant, what the physician is going to do is the physician will track the beta HCG levels in order to make sure that the beta HCG levels are doubling as they need to be doubling, which will show that the fetus is developing as it should. Beta HCG levels provide a lot of information in the form of embryogenesis and embryo development, because if the beta HCG levels are elevated and then the female starts to feel really sick or start to have a lot of irregular bleeding, and then we see the beta HCG levels drop and they're not doubling as they should, well, that can indicate a miscarriage, and that's the time you really need to consult with the OBGYN to see what the next steps are. So as I mentioned, mifepristone and misoprostol are given together, but mifepristone must be given, in order to elicit the abortifacient effects, must be given orally during the first 7 weeks of pregnancy, and then abortion will usually occur within the next 2 to 3 days. And to stimulate the uterine contraction and to ensure the complete expulsion of the detached embryo, the mifepristone is usually combined with misoprostol, which is administered either orally or vaginally about a day or 2 days after the mifepristone administration, to make sure that the abortion is complete. The FDA approved the oral contraceptives, which contain estrogens and progestins for use in preventing pregnancy back in the 1960s. Oral birth control is about 99% effective, and the pill is taken daily for 3 weeks beginning at the onset of menstruation. This 3-week intake is followed by a week of which the female will either take no pill or a blank pill that lacks hormones. And the mechanism of action of how the hormonal contraceptives work is they exert their primary effects by inhibiting ovulation and impairing the development of the uterine endometrium. And they are not only given orally. There's many different types of contraceptive methods nowadays. You can give once monthly injection can be given by an MD. There's a transdermal patch, there's subcutaneous implants, there's vaginal inserts, and there are also intrauterine devices. So again, you don't need to memorize any of the hormonal contraceptives that are listed on the slide here. I just want you to be aware of their general existence. Please be aware that hormonal contraceptives do come with a series of adverse side effects, including potential cardiovascular complications, such as venous thrombosis, ischemic stroke, and myocardial infarction. And I will leave you all with this slide, the special concerns for rehabilitation patients. Please read through this. This is the main takeaway points that I want you to get from this lecture.